Thanks for coming, everybody. Now, Dan covered my little background here. Nice to see everyone coming in. I usually love to teach on super fun stuff, like, wheelchair skills, or yesterday we did sports. That was a blast. And then I got adverse events because this is my day in and day out job with the National Center for Patient Safety with the VA. So it's kind of a little dry subject. So we're going to see how much fun we can have with the dry subject of adverse events in wheeled mobility. So I think it's good information. I think we need to be on top of what's going on in our industry with managing risk and avoiding harm to the clients that we're taking care of with wheeled mobility and seating devices as a background there. Nothing to disclose. I get no money for doing cool stuff other than my government salary. And then, of course, I have a lot of opinions and a lot of things to say, so it's all my stuff. And you guys can't hold the University of Pittsburgh responsible for any of that. So a lot of fun. Want to get through this with hoping that all of you gain new information about what are the options for reporting adverse events when they occur. So who should be reporting? How do we report them? What are the different options that are available? And we'll move through those. Understanding why do we report events? So great, I have options for reporting events when they occur. Why would we want to do that? What are we trying to encourage across the industry? And then outline two scenarios where concepts of what we call high reliability organizations can be applied to this concept of event reporting and data analysis related to adverse events. So we'll go ahead and jump right in. I'm taking a look. These are some of the incidents that occur that we get reported. I feel like my voice is inconsistent with my thing. Do you guys hear that? Usual? Okay. Key issues that are adverse events that we experience all of the time is falls. So I'm going to go through some of the key issues where we have incidents reported, and individuals commonly experience falls from wheeled mobility devices, and there's a variety of reasons. We'll go through some of those. You would be surprised at the kinds of falls that occur. It's not, just when people are transferring in and out of devices, but while they are propelling a manual wheelchair, while they are driving a power wheelchair with various types of controls, people are falling out of their wheelchair. They're falling with their wheelchair. So it's one thing when an individual experiences a fall while they are attached to their manual wheelchair or come out of their manual wheelchair. It's something else entirely when they are well attached to their power wheelchair and experience a fall with that wheelchair attached to them. And so we'll go through some scenarios where we've seen that, obviously some catastrophic potential outcomes when that occurs. So we see falls, and we see a lot of different types of injuries, either related to a fall or related to other incidents associated with the wheelchair. So we look at things minor to catastrophic. So injuries to the skin, you guys are well versed in those types of issues with abrasions, to pressure injuries. Fractures are a common type of implication with injuries that occur related to incidents with wheeled mobility and seating. Traumatic brain injury, someone falls, somebody has an incident where they smack their head on the concrete, on a wall, on the bathtub, whatever that might be. So these are catastrophic types of issues. And of course, it's difficult to talk about when people experience an adverse event that results in death. And we have folks in the room and folks at this conference who, spend extra time serving as expert witnesses in cases where what went wrong in this case and where is the liability for this person dying as a result of an adverse consequence related to their wheeled mobility. So absolutely, catastrophic. This, I know it's a little bit bright up here. Can you guys see that? Okay, but looking at, of course, this clavicle fracture in orthopedics and physical therapy is my background. Not such a big deal. It hurts a lot, but most people heal up from a clavicle fracture without surgical intervention. So the outcomes are pretty good. Very different scenario when the individual experiencing that fracture is a manual wheelchair user or, using assistive technology in any way. And it really carries a significant implication, of course, for the clients that we serve when they are now experiencing a catastrophic injury as a result of an adverse consequence. This is an individual who is one of our world-class skiers, 6-time Paralympian. And so when you're that type of individual using a manual wheelchair is literally chasing the snow and skiing more than 200 days a year and now experiences a fracture. They're out of that game, but also everyday life of transferring, getting in and out of bed, dressing, taking care of themselves. You guys are all nodding your heads going, this is a real significant issue for the folks that we're taking care of every day. Additional adverse consequences, if things creating an issue is people get stranded, right? So those of you that have been involved in looking at adverse consequences is when a device needs to be repaired and can't be repaired quickly enough, people are stranded. Worst case scenario, stranded in the community, right? Somewhere out and about, stranded at the intersection because a caster falls off. Stranded at home is a better place to be stranded, but not ideal either. And we had a report in the VA several years back, it's been about 3 years now, from our Office of the Inspector General, and basically looked at consequences related to delays in repairs for power wheelchairs and scooters. And the worst case scenario was an individual stranded in their hospital bed at home for 107 days while they were waiting for their power wheelchair to be repaired. And if you think about that, that's 4 months, 3.5 months or so. If you were just stranded at your house and you couldn't get out and about, that's one thing, but confined to bed because your power wheelchair is not being repaired appropriately, just unacceptable, right? Completely unacceptable. And this is where we're looking at what are the adverse events? How long is it taking us to resolve these events? And how can we improve our processes so that that doesn't happen to another individual? And that's what this is all about, is reporting incidences so that we can improve organizational leadership and operations so that we can mitigate those issues from occurring again. So we'll go through some of these issues. What are the causes? I think it's really important to understand what are the causes of those adverse events that we see reported in a consistent basis. I feel like I'm blocking you guys over here. Devices malfunctioning, so not operating the way that they were intended to operate, or having a compromise in the operations. Complete failure of the device, so it's just not working, or something breaking entirely. The wheel broke, the camber tube broke, different things that we see occurring of things just completely fail. Design challenges can result in adverse events. So if a device is difficult to interpret, difficult to use, difficult to find the function that I'm looking for, it's more likely that a mistake will be made, okay? And so we look at design challenges as a cause. User error, okay, user error, people just making a mistake in how they're using their device, or user error to the point of negligence, like I'm using my device inappropriately and I crashed into a wall, or I crashed into another person and I caused my own fracture. That can be an issue as well. Communication challenges, and I think this is one that we see often as when we do a root cause analysis and look at what happened where this individual fell with their power wheelchair attached to them, is often a communication challenge, okay? So I don't see a lot where an individual fell out of a vehicle. So for example, when you see that type of issue, say you have a vehicle that has a platform lift or a ramp, and an individual is driving with their head and just does not have a good visual field for what's going on around them. When there's a communication challenge between the driver of the wheelchair and the driver of the vehicle, of is it time to come out of that van or not? That communication challenge can be catastrophic when an individual driving with their head is exiting a van where they think the platform lift or the ramp is deployed. Is it in place when it's not? And that's where we see those types of things. We've also seen those types of falls where an individual, again, visual field, user error, lack of training, whatever that might be, where they are not perceiving where the curb is. Where is the curb? Where is the flight of stairs? Worst case scenario, and we don't share all the details of where things occur, but an individual going home on like a first pass to go home for the day and see how they're doing before they come back to their institution, and out on the back patio, not understanding where the flight of stairs going down to the main level of the backyard, and a fall with a power wheelchair can be catastrophic there. So those just perceptions and judgment and vision. And I really think, looking at why are people getting injured, it's their lack of ability to perform their skill set in their power mobility device and their manual mobility device, perhaps related to deficits in performance that can be associated with lack of training. Okay, so if we're not teaching strong wheelchair skills, whether it's driving or propelling or jumping that curb or getting up a ramp without flipping over backwards, we will see individuals that sustain injuries as a result of that consequence. So just kind of a wide range of causes of why people get injured in using those devices. We have a lot of great publications, and I encourage you guys to be searching the literature to better understand what goes wrong, what could go wrong, what's going wrong. This is a study from 2016. It's several years old, and I'm sharing it as an example strategically. The type and frequency of reported wheelchair repairs and related adverse consequences among people with spinal cord injury. And when you look at kind of the summary, they looked at repairs over the prior 6 months. So when we worked with these individuals as subjects, they had 591 subjects in wheelchairs and seating. That's a robust sample size. 63.8, 64% required at least one repair in the last 6 months. 28% experienced an adverse consequence as a result of needing that repair, and 18% of them were stranded somewhere as a result of the repair that was needed. So it's pretty significant numbers back in 2016. Primary causes were the power wheelchairs, were the electrical power and control systems, and with manual wheelchairs, it was wheels and casters. I see people in the room where their career work is, wheels and casters. And this is why, because when wheels and casters fail on a manual wheelchair, people get stranded, right? So it's a real problem. We jump ahead. This is a 2021 publication looking at a similar group. Factors influencing incidence of wheelchair repairs and consequences among individuals with spinal cord injury, same population, over 500 subjects. And these are from 9 spinal cord injury model systems around the United States. In the past 6 months, 56% of them required a repair of some type to their wheeled mobility devices. 42% experienced an adverse consequence as a result of that repair that was needed. And the highest repair rates we're looking at seating systems, electronics, and tires. So we're seeing common themes there. 42% of them experiencing at least one consequence in the last 6 months. Pretty significant challenges with need my device repaired, experiencing an adverse consequence as a result of that. I really like this study for, I love the opening plenary yesterday of looking at diversity, equity, and inclusion. And I think that we're stepping up to the plate and seeing what's going on with our consumers of wheeled mobility devices. In this particular study with Lynn Morby as the primary author, they found that repairs were more common in people who are Black or who use power wheelchairs, okay? And consequences were more common with those who are Black, use power assist, or are using public insurance to fund their devices. So we're looking at issues of equity and what's going on with individuals that we're working with. And we're trying to better understand, is there equality, equity? Is there a difference in the people that we're taking care of, in their situation, in their socioeconomic circumstances, in terms of what are the consequences when they experience an adverse event? It's always great when the author of the study is sitting in the front row, right here, Laura Rice, published several years ago. We have populations of people that are experiencing adverse consequences. So Dr. Rice published on fall prevalence in people with multiple sclerosis who use wheelchairs or scooters. It is startling when you look at the last 6 months, 75% reported a fall in the past 6 months. 48% of them sustained an injury, and 87% of those falls occur at home. And so when we look at incident reporting, we're going to go through options for incident reporting. There's this balance of, are we even seeing the majority of adverse incidents that are occurring? We know what occurs in healthcare facilities because we have requirements to report it. We know what occurs in public areas because there's a requirement to report that. When Dr. Rice reports that 88% of these falls are occurring in the home, chances are that we're not even receiving those as a report unless the healthcare provider is asking, or unless there's a reason in a re-evaluation for that next device of, hey, did you have a fall in this past year? Oh yeah, by the way, I fall 3 times a month, that sort of thing. And so most likely these issues are underreported across the board. This is a recent study, again, out of the University of Pittsburgh with the entire team that's hosting this event. When we're looking at functional mobility, employment, and safety benefits of seat elevating devices. So there's been a lot of discussion during this conference of CMS looking at opportunities to provide funding for seat elevators, and looking at the conclusion that use of a seat elevating device on a power wheelchair is associated with higher functional mobility assessment scores, which is a good thing, increased transfer scores, which is a good thing, higher unemployment rates, awesome, and lower rate of self-reported falls than using a power wheelchair without a seat elevating device, okay? So when we look at some of these publications and issues, we are building technologies, we are advocating for the funding of technologies, we are doing this good work to keep people safe. And I think, you know, I work for the National Center for Patient Safety and VHA, and it's so easy to capture everything that we do in rehabilitation under the umbrella of safety, right? We want to get people out doing what they want to be doing, enjoying their life, participating to the greatest extent possible, while remaining upright with whatever their upright might be, and keeping them free of harm from the services that we provide. So kind of looking at different issues. When we look at falls as adverse events, this was from the Joint Commission. And I want to pause and ask, who in this room is not from the United States? Raise your hand. Not from the United States? Okay, great. I will highlight, you will see highlights. Of course, I work in the United States and have access to this information. My encouragement is I cannot represent what goes on across the world. You should have parallel systems in your countries for this type of reporting. The manufacturers, the products are the same. The focus on health and safety is the same. So I just encourage you to look at the same issues in your countries and find out what your mechanisms are for accessing that information. I don't mean to be American centric, but in this topic, it's kind of hard not to be. So the Joint Commission is an oversight body over our healthcare facilities. And back in January of 21, there it is right there, 21, they identified that any fall resulting in any kind of fracture is what we call a sentinel event. And a sentinel event is the most severe type of event where that results in an individual sustaining some type of permanent harm or requiring medical attention as a result of that harm. And it really kind of was a game changer, because in the past, it was any major fracture, like a hip fracture or, you know, a femur fracture, whatever it might be, would be a sentinel event. If an individual falls and fractures a bone in their hand, it is considered a sentinel event that must be reported and managed appropriately as the most severe cause of injury. And so you have that definition there. It's a really important piece of legislation that came out of Joint Commission requirements for reporting. And these are just some of the definitions of what are all these types of events. Okay, so adverse events, you know, something went wrong. So it's a bad incident, an untoward incident, iatrogenic injury, or other unintended harm directly associated with care or services. So we provide care or services related to wheeled mobility. That's an actual event that occurred. Something happened, which is different than a close call. So it's a close call. Another term is a near miss. There's other words out there that people use, but it's an event or situation that could have resulted, really close, could have resulted in an adverse event, but did not, either by chance, like we just got lucky, or by intervention. I caught myself. Let's get those anti-tip bars back in place. Such events have also been referred to near miss or potential events. The sentinel event is the most severe type of issue, where a patient safety occurrence that involves death, serious permanent physical or psychological injury, or severe temporary harm and intervention is required to sustain life. So our most severe types of incidents are sentinel events. And so when you look at a fall with any kind of fracture is considered a sentinel event, we're capturing a lot of adversity related to the clients that we're taking care of. When we just talked about, they're all falling. Okay, people are falling, and they're predominantly falling in the home setting. I wanted to go through some options. Again, I'll highlight options in the US. Those of you that are not in the US will have options in your country for reporting these types of events. So we're going to move into a section of how to report and how to access data. In the United States, the US Food and Drug Administration, the FDA, regulates wheeled mobility devices as either class 1 or class 2 devices. So your manual wheelchairs that are considered to be lower risk are going to be our class 1 devices, and power wheelchairs and similar types of devices with power control systems are class 2 devices. And if you guys are familiar with all of those, there's a higher risk of something going wrong with an individual who has more complex impairments using a power wheelchair. So these are just a list of things that the FDA requires, the US Food and Drug Administration requires manufacturers to register their company, to list their device, to prove that it's been tested, which is really important. We could talk a whole day on testing. And basically, confirm that this device is appropriate for distribution in the United States. I always, people go like, what about that basketball wheelchair? So the FDA, it's really important, what do we not regulate? So it's a little bit nutty that the FDA does not regulate sports equipment. So if it's a manual wheelchair, we regulate it. If it's a basketball wheelchair, we don't. Okay, so a little bit challenging there with the discrepancy. Sports wheelchairs, adaptive sports equipment, they do not regulate power add-on systems that you're attaching to manual wheelchairs or all-terrain vehicles. Now that's vehicles, not wheelchairs. So if it's an all-terrain wheelchair, it is a power wheelchair and is therefore under the regulation of the FDA in the United States, which is different than an all-terrain vehicle that somebody gets on and is riding around. They may use a wheelchair and ride an all-terrain vehicle, but that is managed by our vehicle and transportation folks in the US. I can't think of their name right now, but there's a whole different realm of regulation when it comes to motor vehicles. So if it's a power wheelchair, it's a power wheelchair. If it's an all-terrain vehicle, it's an all-terrain vehicle, and there's different regulations that support those. So again, if you're looking at devices that are power wheelchairs intended for all-terrain access, they are regulated as a Class 2 medical device in the United States. Really good question in the US, is this device cleared for marketing? So the appropriate term is cleared for marketing. The FDA does not approve most things. Okay, the only thing that the FDA approves is Class 3 medical devices, which are your most intense medical implementation types of devices like a cardiac implant. They will approve or not approve those types of high-tech devices that are implanted in people. They approve or not approve drugs and pharmaceuticals, but they don't approve medical devices used by people. So is this device cleared for marketing by meeting all of these requirements? If you ask, is your wheelchair approved by the FDA? I hate to say it, but that's kind of a dumb question that we hear all the time, right? We always say there's no dumb question. It's kind of not the right question to ask. Is your device approved by the FDA? Because they don't approve it. So it'd just be kind of a crazy thing. So I put up, and then I throw all my slides. It's just my reminders. I don't have notes. I don't look at anything, but the red flag is if you ask, is your device cleared for marketing by, cleared for marketing by the FDA? And the answer is no, or I don't know, that is a red flag. Okay, in this industry, that is a red flag. So you're looking at that. Who should report adverse events? Shout out, shout out. I wanted to do a little polling thing, but I just didn't get around to that. Who should report adverse events? Oh my God, you guys are so smart. Okay. I think that just sometimes there's a misconception that there's a limited number of people. Only the manufacturer can report adverse events, only the healthcare provider, only a doctor. Anybody that is aware, like anyone aware of an adverse event has the opportunity and the responsibility, in my opinion, to report that adverse event. And again, we'll go through some concepts of high reliability organizations and what we call just culture. I want to highlight that it's not intended to be punitive. We're not reporting events to say we're going to put you out of business. That is not the goal. We are reporting events to learn from those events so that we can prevent adversity from occurring in the future. So manufacturers, healthcare providers, consumers, anyone that's aware. And again, FDA, because they regulate this industry, they carry the responsibility for managing adverse events in the United States. You'll have similar opportunities in your countries. It's really easy to do. I see people in the room where I'll get a phone call of like, this occurred in my clinic, this occurred in my patient's home. What should I do? File a report, medical device report. This is just a screenshot from our FDA website. And the reason I put this up here is if you're a health professional, you choose this form. And if you're a consumer or a patient or an advocate for a patient or consumer, you choose that form. And it's a really simple form to complete. I'm looking at Kathleen because I know she's gone through this process. Pretty reasonable to enter the information about the incident. What's the device? What occurred? What is the assessment from the clinical perspective? That gets submitted to the FDA. And what's cool about it is whether it's a healthcare provider or a consumer providing that report, the manufacturer then receives the copy of that report and has a responsibility to reply, because the FDA is regulating their device in this realm. So it's nice, and I'll show you the examples of what you get from a report and then a response from the manufacturer. Really easy to download, also available in Spanish in the US, and I'm sure, different languages as appropriate if needed. So this is what it looks like in the VA where I work with our veterans here in the United States. We have an internal system as well. We report in both places. So if there's an issue that needs to be reported, with a medical device concern. We also have an internal system. We share it with the DoD, which is our Department of Defense. And basically, any individual working in our healthcare system has the opportunity to report an adverse event. They can identify themselves or not. So there's just a lot of issues with, people fear of retribution. We're, changing that with adverse event reporting, but anybody can plug in their card. They can enter the information that occurred. I mean, it could be anything. It could be a wheelchair issue. It could be a wrong medication issue. It could be somebody slipped on the floor because there was water, whatever it is. And that information is entered into the system. So my office, the National Center for Patient Safety, manages this entire structure and basically allows individuals to enter as much information as is available. And if there's a concern that this issue extends beyond my facility, they can mark that for national attention. And then that's where my office at the national level receives that information and says, this could be a problem for other professionals in our system or for other veterans that we take care of. And then we have mechanisms of communicating that concern when appropriate with the rest of the country. And so if we see an issue with any type of medical device, if we see an issue where this occurred with a manual wheelchair, and we know that we've purchased X thousands of those manual wheelchairs, we now have 6 reports of different things, we're thinking this is a bigger issue, and we're going to take action to communicate with the manufacturer, communicate with the FDA, get the information out to the field. Again, not to be punitive, but to provide awareness that this might be an issue and we have an action to prevent people from getting hurt. So internal to the VA, we have this system. And those of you that work for VA, how many are VA? Good. And we can have a whole separate conversation about stuff because, again, I think we're under-reporting in VA. So I know we are. I know we are. Folks are not aware how easy it is to just plug in and submit. And again, big data drives change, right? So if we see 1 case, okay. If we see 12 cases, okay. If we see 12,000 cases, we're gonna see that. And with 350,000 employees in the VA, we can impact some change with entering information that can drive change. With our event scoring in the VA, and it's just, again, premises of how do we evaluate adverse events. When an event is entered, we do what we call a SAC score, and it's a safety assessment code, and basically is identifying what is the severity of this adverse event, okay? So we look at, what is the severity of the adversity that occurred? How frequently do we expect this to happen? Is this a one-time thing? Probably not ever going to see it again, or is this something that could occur daily in our healthcare system? So raises that safety assessment score. And then we are able to look at aggregates. So when we see falls from power wheelchairs over time, we can look at a summary of that information and see if we can identify themes so that we can identify the appropriate strategies to address those issues. So if individuals are not performing well in their wheelchair, and we can identify the theme that we're not providing appropriate skills training for that individual to be operating their wheelchair, then we can create an implementation to address that challenge. So that's what we do in our system. And again, this is a website for our group. When you have those most severe events, so a SAC 3, that's the highest level, any sentinel event, there's a requirement to perform a root cause analysis. And it's the same thing in most regulatory bodies across the world. When there's a severe adversity, we need to put together a team. We need to gather the information that's available. We need to interview, collect data, identify factors, identify themes, and figure out what is the root cause. What happened to cause this incident to occur? Because it's one thing to report, but it's a whole other strategy to understand what went wrong so that we can identify how big of a deal is this, and do we have any opportunities to mitigate this issue from occurring again. So it's already done. The event already happened. There's nothing we can do. I'm the queen of hindsight is 2020. Those who know me well, like, oh, I shoulda, coulda, woulda. This event has already occurred. And we can learn from that event and prevent issues from happening in the future versus saying this occurred and this occurred again and this occurred again and this occurred again. So it's really a great opportunity to take a look at these events. In the US, again, part of the FDA regulation of devices, we have the manufacturer and user device experience database. So now we're moving into, everyone has a responsibility and opportunity to report adverse incidents. What data is readily available to you? It's all at your fingertips. This is public information. Most folks just don't know about it. So we refer to it as the MAUDE database. It is public domain. You can go to fda.gov, plug in MAUDE, M-A-U-D-E, Anybody can search the public database for information that you are looking for adverse events. And so a lot of folks, are looking for, gee, I'm looking at this new device. It's been on the market for 2 years. I have a client that's now asking about it. I go to the mod database. Have there been any problems with this? And it's so easy to search through this information. So available across the world. It's a robust data set of gazillions of pieces of information. I was quite strategic. So instead of plugging in a wheelchair manufacturer or cushion manufacturer and showing all the adverse events that pop up, I went to the exoskeleton industry, right? Just to be safe. Because again, this is not about calling anyone out. It's not about punitive action. It's about learning from what went wrong and what happened. And so all of these devices are entered by product codes. There's lots of different ways to search. There's great tutorials online. They've got YouTube videos. They've got, step-by-step strategies. It's easy to learn how to manipulate this database. But for example, when I type in PHL, which is the product code for the powered exoskeletons, you choose a time frame, so you can look at the last 6 months. You can look at they keep 10 years active on the website, but I can type in PHL. This is the last one that was reported was in September of 2022. And this was kind of cool. I plugged it in and then it's like, okay, we have Rewalk and Exo and Indigo, and all of them are represented with adverse events that have been reported as they should be reported. And then what happens is then if I were to click on one of these, so when I click on one of these, it shows the information that was entered for that adverse event that occurs for that individual. So the event description goes in first. You never know what you're going to get. This one says the user has crashed in his home while training in his system. I'm not sure what the P means. He has trained with his certified physiotherapist. He wanted to go around the table and fell for unexplained reasons. So this was the event report. And then the manufacturer is required to provide a narrative after their assessment of that report. And so in this particular case, I won't go through all the details, but they basically are documenting that the individual was trained, that they went through appropriate mechanisms. There were no system disturbances related to the fall. They go through that analysis, and then he has completed the basic training and is already partly done in the advanced training. So they're going to document what they know about the event as well. I like this system because it allows the manufacturers to gather more information to better understand what happened. We're trying to make progress. Oftentimes when there's an adverse event with any kind of medical device, I'm talking, it could be a wheelchair, it could be an MRI machine, whatever. We deal with all of these issues in our office. We usually get one of two responses from the manufacturer when it's a phone call or when it's an email. One of two responses. One is, we've never heard of this before, right? Never heard of that before. Well, you already responded to it 22 times in the last 6 months, according to the mod database, right? So we hear, never heard this before, or it must be user error. Those are the two things that we always hear, okay? So a phone call is one thing. Talking to your manufacturer's representative is a conversation. If it's not documented, it didn't happen. So I recommend, again, just to get the information logged in appropriately, I recommend communicating by email at minimum and documenting in the database so that those pieces of information, maybe nothing will come of it, maybe it was user error, but that requires an analysis to determine what the cause of the adverse event was. So just gives you an example of how that goes in and empowers us with information. When someone says, we've never heard of that before, it's like, yes, you have. Yes, you have. So we're entering that information. The other pieces of information that are readily available to you at your fingertips, and I recommend that you become familiar with medical device recalls applications. And so there's two different kinds of medical device recalls. And again, wheelchairs are medical devices. Remove from use means this entire system needs to be removed from use from a medical center or needs to be removed from use by that individual who's been provided that device. It can be the entire system. It can be a component of the system. So I remember, it was painful. It was probably 6 years back. Do you guys remember when Invacare recalled the joysticks on power wheelchairs? I think we had to remove and replace 28,000 joysticks for our veterans across the country. It was a painful experience, but there was an adverse event that occurred using the joystick on an Invacare chair. And that's a responsibility to remove from use and replace that joystick so that nobody is harmed as a result of that. Invacare handled it appropriately. we took care of our veterans by making that happen. The other kind of recall is a field correction. So you'll see it posted as a recall, but it's really what we call a field correction. And a field correction could be, this needs to be fixed. So the power wheelchair is fine, but we need to add this heavy duty seat to back bracket because we've had some failures. So it might be correcting something. You will see a recall when there's an update to the instructions for use, an IFU, instructions for use. We call it the owner manual, we call it the user manual, it's instructions for use. So if there's an update to instructions for use that's related to safety, they'll post it as a recall, and then we need to notify all people that are using that device about this update for instructions for use. This applies to devices, like I said, that are used in institutions. You can have the same wheelchair that you're using in your institution and is owned as capital equipment. You have the same wheelchair that's been issued to one of your clients, okay? And so if it's a recall, and it's going to apply to both in that situation if it's used in that type of area. Obviously, people don't have, radiology equipment in their homes, but in the realm that we work in rehabilitation, it's often covering both devices issued to people and devices used in institutions. So again, with the FDA regulating our use of medical devices, the recalls database, it's so easy to use. You can just type in, I didn't do the same example, but you can type in a product name. If you want to know the product code, I can type in PHL for exoskeletons, and it's going to tell me all the recalls that have been posted. I can select my time frame and be aware of those. So with your institutional operations, you should have a system in place that somebody is looking at recalls that have been posted at least on a monthly basis, if not more frequent, to make sure that we're not missing anything. You can subscribe to whatever listservs you want to get. I get hundreds of messages from the FDA because at my office, we have to stay on top of everything that comes out on recalls. I get all sorts of stuff. And I'm like, hey, friend that's using this stroller type of thing, this has been recalled. You need to be aware of that. Just depends who's doing what in their life. But again, you can easily search what's going on there. Anticipating questions, you guys are like, well, what are those codes? Because they're not necessarily easy to find, but these are the codes that you would search for different types of devices. So the powered exoskeletons I threw up there because I used it as an example, but power wheelchairs are ITI, manual wheelchairs are IOR, a stair climbing wheelchair is an IMK. So you can search by product code and see all of the recalls that have been posted in a time frame for that particular area. I haven't put them on the app, but I will make sure you guys have a PDF copy of slides. You can take pictures if you want. There's nothing confidential here, but just wanted you guys to have the tools to know what's readily available to you so that you can look at these issues. So I'm gonna grab a drink of water. All my people, I have water, I have coffee, I have all of this. Little break. I've gone through information about what are the issues, what are the adverse events that are occurring? What are some of the opportunities to report? What are our databases available to understand what's going on in our industry? So you guys, I want just to encourage you, when you guys get back, start thinking about what do we need to know about adverse events and how can we implement change to keep people safe. Another area that I'm heavily involved in that is related to adverse event reporting and management is the implementation of what we call high reliability organizations. Okay, and we could talk for a whole day. We did do a whole lecture last year on high reliability, so available. It's remotely recorded from ISS 2022 when we were all virtual still. So if you want, a longer version of HRO, you can access that. But basically, high reliability organizations are implemented in other industries, like the airline industry, like nuclear power, high risk industries, and healthcare is part of a high risk industry. Okay. Adverse events, adverse medical consequences are the #3 cause of death in the United States. Crazy. Adverse medical incidents are the #3 cause of death. #1, what do you think? Heart disease. #2, death, motor vehicle accidents. Okay, so heart disease, motor vehicle accidents, and then medical errors is why people die in the United States. It's frightening. But basically, high reliability in healthcare is here. It is embraced by the World Health Organization, by all of your countries. I love the World Health Organization website about high reliability organizations. and why it's so important to implement characteristics of high reliability in taking good care of people that we're serving in our healthcare institutions. This was a evidence brief that was done. It was back in 2019, so we have some updates to do, but in the VA, we have a whole program of evidence-based synthesis program where we can provide a topic and say, I want everything that's available in the past 10 years on this topic of implementation of high reliability organizational principles. And then we get a report that says, here you go, this is everything you wanted to do. And we use that information, that's all the publications that have been made available across the world, and then we can implement changes on an evidence-based approach. So what's really important, and I want you guys to be thinking, because we're going to talk about wheelchairs and wheeled mobility applications, 5 characteristics of high reliability organizations. Sensitivity to operations. That's understanding how things work from beginning to end. Okay, and what we're doing, we work in complex systems with complex people. Okay, so understanding getting from point A to point B is not a straight line, but rather a circuitous route to take care of these folks that we're serving. Preoccupation with failure. You guys will leave here and you're going to be scratching your heads going, what could go wrong? What could go wrong? Once you are embedded in these types of characteristics, you just think that way. You're always looking for, I'm working with this client, I'm working with this kiddo, I'm out in the yard, what could go wrong? Because adversity is right there all the time. We're preoccupied with failure so that we can anticipate what might go wrong and implement strategies before there's a problem. Reluctance to simplify is there's no simple solution to challenging healthcare issues, right? So I'm looking at a lot of nodding heads. The people that we're working with are not straightforward. They have a whole long list of problems. They have issues that occur. We're not going to have simple solutions for complex issues. Commitment to resilience means bounce back, learn from our mistakes. Okay, so there's an issue, there's an adverse event, we can wallow in that, and it's appropriate to to react appropriately, but our greatest power is to learn from that mistake and bounce back and implement strong systems to prevent that from happening in the first place. I love this one, deference to expertise. Okay, defer to the experts. And you guys have, many of you, I see a lot of familiar faces. I didn't pull it in this time, but I always have my Easter egg basket slide that shows there's all sorts of different professionals involved in this industry. So our clinical providers, our technical experts, the manufacturers, the funding sources, everybody brings something to the table. And we have to defer to the expert, which is often the client. If we go back to listening to that plenary yesterday, listen to our clients. What do they need? They're the expert in their own life and their own situation. And we have to defer to those who have expertise in order to help us make good decisions in management. Here in the United States and Canada, the Rehabilitation Engineering and Assistive Technology Society of North America, we have a white paper on guidance for the service delivery process for wheeled mobility and seating. And it's just that, you guys have seen, many of you have seen this, starting with the assessment, going through equipment coordination and trials, moving through preparing product, making adjustments, providing the appropriate education and training, measuring outcomes, providing follow-up maintenance and repair. The complex cycle of intervention. Sometimes it's more straightforward, sometimes it goes on for years, right? But you can apply each of those characteristics of high reliability to our service delivery process for providing wheeled mobility. And when we're looking at these different applications, we have a responsibility to really look at how does this device work? What do I need to understand as a clinical provider? These are all clinicians. Hi, Meg. Meg's over there. Meg's over down here. I got people all over here. This is Dr. Perlman, the chair of the department many years ago. But getting in those devices and understanding how they work, that is sensitivity to operations, right? If we just have a device that's shown to us and we go, yep, that's working out really well. How do you know? You got to know how to drive these things. You got to know how to perform wheelchair skills. You got to understand the impact of making an adjustment. You move that rear wheel forward because it's the right thing to do until it's too far forward. And then that's a problem because someone's going to flip over backwards when they go up their ramp, right? So just different opportunities to apply these principles to what we do. This is a great example of when you guys are out in the exhibit hall. I shared this, I think it was back in 2020 in Vancouver when we were all together. And I staged this picture of so often we are in the exhibit hall and someone's showing us that device and it's like, this is great, here's our new innovation, we launched it at the party last night, whatever. Isn't that awesome? It's like everyone's standing there like, arms crossed. Yep, looks great, looks great. That's so neat. Get in that device, right? Get in that device. Total staged. I love it. Meg's in the room. I love this. Getting in the device. How does it work? How am I going to program? What are the implications of changing the programming? Let me drive it. And so I say butts in chairs. Get butts in chairs. When I see you guys this afternoon in the exhibit hall, if anyone's standing there with their arms crossed, you got a problem. You're going to get your butt in that chair. To understand, like, get in these devices. You should be trying them. You should be understanding how they work. These all-terrain devices. Here's Mark. We were doing some all-terrain stuff. You got to get in those before you make a recommendation for somebody with a severe disability to get in these devices in terms of being safe in the environment that they're functioning in. Whole different beast in working these issues. And I encourage you to get in these devices and understand how they work. Same line of sensitivity to operations. I just grabbed one little example. What's required to use this device safely? Same type of thing, understanding it. What's required for clinical providers to make recommendations, for consumers to use it, for caregivers and companions to be an appropriate caregiver and companion, and what's the technical support needed, okay? I'm a huge advocate of innovation. I love all the cool new stuff coming out there, but I always ask, what's required to implement this new innovation? It's so cool, it's so neat, it does everything possible. How many days of training? I can go back to the exoskeletons, because no one's going to be offended in this room about the exoskeleton. Multiple days of training, okay? I see some of my colleagues in the room. So I need multiple staff for 3.5 days to be trained in this device, and it's a cognitive load, and then we have to teach someone how to use it, and it's a cognitive load for them, and then you have to maintain competency by doing it all the time, but we're not issuing exoskeletons all the time. So when a year goes by, I forgot how to do all of that. So now we need to do repeat training, and I just think about the grid of the horizontal being the innovation and the education and training that's required. And we have to have an understanding of what does it take to implement this device. That's sensitivity to operations. How do things work? Not just how does the device work? How does the plan work? And sometimes there's a detailed, organized training protocol for clinicians to be competent and to prescribe and train and do everything. Sometimes that's in place and sometimes it's not in place. And we have to figure it out step by step by step, how to do that. The importance of event reporting. So I want to tie together importance of event reporting and high reliability organizations. High reliability organizations depend on engaged staff that are actively reporting adverse events and close calls to drive improvement. We've got to understand what's going on to drive improvement. We investigate incidents, not people. Okay, so we're not saying Jackie made a mistake, Jackie, you're fired. We are looking at there was a problem here. Jackie was involved. Let's interview her to understand it, but there's an incident. We need to understand this incident. We need to support Jackie to understand it. We need to support her with training. We need to support the rest of the staff. Okay, so we're evaluating the incident, not people, and we're encouraging learning and change behavior to improve the environment or both. Okay, so it's really a positive approach. We learn from close calls, adverse events, and sentinel events that are evaluated. Love this component of high reliability organizations, and I think we can do a lot better in our industry of supporting what we call a just culture. And if people go, just culture, are you talking like, legal stuff? Think of it as fair. A just culture is a fair culture where we're supporting each other to understand our work and take good care of the clients that we serve. So I'll read this. A just culture requires establishment of psychologically safe environment where individuals trust that they can and should report errors without blame. So I should feel comfortable reporting that an error occurred. When errors are reported, they should be explored organizationally as a learning opportunity and examined for operational components that can be improved. That's a just culture, okay, where I feel safe saying, I made a mistake, and I want to share that mistake with others so that it doesn't happen again. In a punitive environment, the opposite of a just culture, people will only report what they cannot hide, okay? In a punitive culture, you're so afraid of being punished for making a mistake that you'll hide it unless you can't, okay? And we're really striving for this just culture. Whoops, excuse me. There was a sentinel event alert published by the FDA a couple of years back, about 3 years back, identifying leadership failures in supporting HRO. Leadership failures are included not supporting safety event reporting, no response to events that are reported, not addressing staff burnout. People are burned out. When you're burned out, you're more likely to make a mistake, right? You're tired. refusing to prioritize and implement safety recommendations, and allowing intimidation of staff that report problems. These are leadership failures. And you guys, I see a lot of nodding heads in the room with like, yep, I know exactly what you're talking about. So in our final segment, why do we make mistakes? Why do we as humans, as professionals make mistakes? Two paradigms. Number one, human error is unavoidable. Okay, human error is unavoidable. I put this up here because I did this one time. I was up in the mountains. It was in the Jeep. It was snowing. I was almost out of gas. And I just drove away and heard clunk, clunk. And I was like, oh my gosh. So when we're distracted, when there's a lot going on, it's easy. No person in the world, you can be as perfect as you think you are, you will make mistakes. Okay, it's unavoidable. No one is immune. The second paradigm is that we drift. We drift. So we start with being diligent and knowing what we're doing. I'm a new grad. I read all the instructions. We got a new product, read the owner manual. I've got a new patient. I know this chart inside and out. And then we drift because we get busy. Okay, so drift is inevitable and unavoidable. No one's immune. However, when we drift, it's a choice. Okay, human error is not a choice. Drift is a choice. And we're going to go through some examples as we wrap things up. Speed limit says 70. Jerry Dickerson, how fast do you drive? 85, 90. Okay. Anyone else? Speed limit says 70. This is the rule. 70. 80. Does anyone drive 70? There's always someone in the room that says 70. Maybe not in this industry, right? I guess some of the nurses are like 70. 68. Okay, but it's very common, right? 77. You know what the rule is, but I feel safe at 77. I don't feel safe at 85 and get pulled over, but we push the rules a little bit. That's drift, right? We know what the rule is, but I'm pushing it just a little bit. Systems are set up where you have, I know this is really a busy slide, but basically you have environments, you have policies, you have your culture, you have teams of people, you have competencies in place, technology and equipment available, complex technologies, but then it's busy, it's loud. I've got too much work to do. Our procedures are not standardized. Everybody does their own thing. We have communication challenges. There's complacency. We didn't retrain on that topic. The technology is changing all the time. How am I supposed to keep up with that? And this is the Swiss cheese model. These are representing pieces of Swiss cheese. And this was written in the early 2000s, about 2001, by James Reason. And it's basically when all of those pieces of cheese, Swiss cheese, line up at just the right time, that's when a mishap or an adverse event is going to happen. Okay. And it's just one little thing. Everything has to line up. So as long as you have good policies in place, you have excellent communication, you're keeping up with your technology and innovation, we're going to put blocks in that Swiss cheese and we're going to prevent these issues from happening. It's hard to do, and this is why we make mistakes. Human error, as we talked about, is a cognitive slip. Happens to everybody, unintentional, didn't choose to make a mistake today. At-risk behavior is a behavioral choice to cut corners. Okay, I know that the speed limit is 70. I'm going to go 77 because I feel okay doing that. It's a routine rule violation. Either risk is not recognized or I'm okay with that risk. I'm going to accept that risk and I'm going to cut corners a little bit. Versus reckless behavior. Reckless behavior is when an individual makes a behavioral choice to consciously disregard a substantial and unjustifiable risk. Okay, so when we looked at drift, we go through and look at, we start out with, like I said, new grad, consistency with policies, right in line with everything, and then over time, right? I get a little bit more relaxed, I get busier, I get distracted, I'm managing people now, and over time we drift towards complacency. And what's really important in HRO is that when we get towards complacency, we got to reboot. We got to reboot and get right back to vigilance. Let's review that SOP. Let's bring in that manufacturer to do some training. Let's bone up on what this diagnosis means so that we make sure that we're addressing all of these issues. We become complacent because of pressures, right? Pressures to get more work done, hierarchical expectations, time, like I said, over time, we become more complacent. There's an absence of a catastrophe, so nothing's gone wrong. So I feel pretty comfortable that we're doing okay. That's when something's going to happen. And then lack of training or training review. Standards, our knowledge just fades away. And we move towards complacency. I'm going to skip this video. for now because we're running out of time, but basically it just shows that it's basically when you're so focused on one aspect of work, it becomes easy to make mistakes in other aspects of work. So it's really a lot of fun, but I'm running short on time. Imagine that. Human error. So we're going to wrap up with human error, an inadvertent mistake that occurs. And I want to apply this to wheeled mobility. So in nursing, distribution of medications, human error, providing the wrong medication to a medication to the wrong patient or the wrong dosage to the right patient. A human error would be, I was working with this individual with wheelchair skills training and I forgot to put their anti-tip device back in place. Okay, just forgot. A human error wasn't intentional. That could be a problem, right? When we look at at-risk behavior, that's when I'm cutting corners. I know what the rules are, but I'm cutting corners. So when we look at teaching wheelchair skills training, so when I, at the beginning of the session, talked to you guys about people are falling, people are getting hurt using their wheelchairs. How good of a job are we doing with teaching people appropriate manual wheelchair skills and appropriate power wheelchair driving skills? We know we have evidence-based applications of how to teach wheelchair skills and the comprehensive list of items that need to be taught, and yet too often those are skipped. I would think of that as risky behavior on part of we as professionals. In risky behavior, speed limit 70, I'm pushing that limit as an example. That's a little bit risky, but I'm okay, which is very different than reckless behavior. Reckless behavior is just a conscious disregard for the rules. And so when we're looking at healthcare, washing hands, unacceptable to not wash hands, right? Wearing personal protective equipment in the appropriate environments, reckless to not be doing that. And I think, a good example would be to not secure a power wheelchair to a vehicle, consciously just saying we don't have time to do that, is reckless behavior. Okay, so it's just, was it a human mistake? Was it risky or was it reckless? Are very different approaches. So reckless behavior would be Jerry driving at this speed, right? Just reckless, right? Someone's gonna get hurt. Someone's gonna get hurt, or you're gonna get a significant fine with doing this. And so to wrap up, I know I'm right at time, and I will I'll stick around for some questions. But basically, with the work that we're doing and the contribution to adverse events, is it risky behavior or is it reckless behavior? When we don't secure, I use the example, not securing the power wheelchair to the facility-owned bus or van. And again, there's no right or wrong answers. I would call that reckless. We did not evaluate the new device before issuing it to the client. Risky, reckless. We did not review the instructions for use with the client. Don't you guys just be thinking about these? We delayed completion of repairs in a timely manner. Risky, reckless. We cut corners on a home evaluation. Didn't get comprehensive information. We allowed a technician or therapy assistant to practice without supervision. Risky, is it reckless? We changed the specifications of the wheeled mobility device that were determined by an ATP or the clinician. So those get changed along the way. Who owns that? Who owns that situation? So risky, reckless, again, no right or wrong answer. But I hope that you all leave here wondering what could go wrong. What could go wrong? And so when you're in the, here's my little segue, my seated segue down to New Zealand, but, it's in an instant, right? We don't plan for mistakes. We don't plan for adversity, but in an instant it happens. And if in your everyday life and in your professional practice, you can ask yourself what could go wrong, I think we have the opportunity to avoid adverse events. I encourage you to be reporting, looking at data, and understanding what we can do to impact this issue.